Greetings again, ladies and gentlemen. Welcome to case study number 39. This is our second child coming in with a cough. This is bread and butter pediatrics, folks, and emergency medicine. So you can expect this to come up on either of your shelf examinations and certainly on a CCS case and certainly in multiple choice questions for both step 2 and step 3. So you've got to pay close attention to this. I strongly recommend that you also watch the other video on a child with a cough. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already stepped up to donate. Okay, we got a 4-year-old black girl who's being brought into the ED by her mom due to sudden onset of shortness of breath and coughing over the last several hours. A few days ago, she was noted by her mother to have a runny nose and a low-grade fever. She seemed to be improving, but developed this current cough overnight. All right, overnight. This is the first time she's experienced symptoms like this. Prenatal, birth, and postnatal history are uncomplicated. Patient has no significant past medical history, no siblings. She's on no medications. She's tracking fine. She's up to date on all vaccinations. Vitals show a normal blood pressure, a heart rate of 122, which is mildly elevated. Respirations of 34, elevated. She's got no temperature, and she's satting 89% on room air. So she is not satting properly. All right. So what are we going to do for physical exam? General, she is coughing, but no cyanosis and pallor. That's reassuring. HENT. Oral and pharyngeal mucosa are normal, but there's some rhinorrhea. So maybe some residual upper respiratory tract infection. Chest and lungs, mild accessory respiratory muscle use, diffuse expiratory wheezes. Would we expect to see this in an upper respiratory tract infection? Absolutely not. Wheezes are a sign of something going on with a lower respiratory tract. No stridor, no murmurs. She's non-tender, non-distended, normal bowel sounds, and no clubbing, cyanosis, or edema. Okay. So our differential here, number 1 is an acute asthma attack. So we really need to keep that number 1 on our radar because that can easily be diagnosed and it can be reversed. So our initial workup, we want to put her on continuous pulse oximetry and supplemental oxygen. You got a patient who's having a hard time breathing or having shortness of breath. Oxygen is intuitive and it is absolutely something you should do. Now, you may be thinking, well, in order to diagnose her, we need to do pulmonary function tests and ABGs and all that stuff. Well, yeah, maybe, but the best thing to do in a young child who's having an asthma attack is to just see if you can reverse it using an albuterol inhaler or an albuterol nebulizer, probably quite a bit better for a patient who's actively having an asthma attack. So we're going to give her an albuterol nebulizer. On CCS, that may need to be selected as albuterol, and then you'll go and click inhaled and continuous. But this is what you do, and then you see if it improves. Now, we put her on the albuterol nebulizer, and we found that the pulse oximeter increased to 100% and the wheezing improved. That's your diagnosis right there. Now, if there wasn't an improvement, then you would need to consider other causes. So the diagnosis is an acute asthma exacerbation. She's going to be discharged on an albuterol inhaler, which will be taken as needed. Prednisone, we can give orally or we can give IV in the hospital, and then she'll need to take it for 5 days. So that's an important part of asthma exacerbation management is to give the steroids. We give very low doses, so we don't need to worry about tapering. And then supplemental oxygen, obviously, in the ER. Management is to reassure, counsel the family and patient, counsel regarding asthma care. That's important, so you're going to have to show them how to use the inhaler. Counsel regarding the side effects of the medications, and follow up with primary care to get a formal assessment. But this is ER management. This is management for an acute attack. Asthma is a reversible chronic inflammatory disorder of the airways. It's characterized by variable inflammation, obstruction, and hyperresponsiveness. Exacerbations are where you get these intermittent episodes of wheezing, shortness of breath, tightness, and coughing. Coughing is important. We typically think of wheezing and shortness of breath with asthma, but you can have exacerbations where coughing is the primary complaint. Now, it is important to recognize that an upper respiratory tract infection can precede an asthma attack. That can cause the asthma attack. So, worth noting in the history. The diagnosis, the best initial test is spirometry, but often you're not able to do that. So the best thing you should do is to give the albuterol nebulizer and see if you see an improvement. That's what you should do with an exacerbation. The most accurate test is arterial blood gases to diagnose the severity of an asthma attack, but we tend to not do that. And the most sensitive test is a methylcholine challenge with pulmonary function tests. Emergency management is the nebulizer, steroids, and oxygen. You got to do that in all patients who have an attack. Long-term management is stepwise and depends on the frequency of the exacerbations. So how often are they using their rescue inhaler? Now, this is how we classify asthma. And this is going to be the same way regardless of the age, but the treatment is going to differ a little bit depending on the age of the patient. So what we really see in a child under 4 years of age is that we're a little bit more conservative regarding these long-acting beta agonists. Whereas in an adult or an older child, we'll go for the long-acting beta agonists, which are used daily, a little bit earlier in the management. With young children, we like to wait because there's conflicting evidence regarding the efficacy. Now, this case was ER management, so we don't need to worry about that. But when they're evaluated by their primary, when they follow up, and if the primary finds that they are using their inhaler very frequently, then we need to figure out where they are on this. Is it mild? Is it moderate? Is it severe? And that depends on the frequency of the symptoms, namely how often are they using their inhaler. Common differentials, so a foreign body aspiration, it'll be sudden, but when you do your physical exam, you will hear a differential on one side or the other. So you may hear wheezing on the left, but not on the right, poor air entry on the left, but not on the right. And this, again, it comes on suddenly. Get a chest x-ray, you may find it, you need to get a bronchoscopy to remove it. Anaphylaxis, very sudden, but also associated with urticaria and a possible exposure, perhaps a history of anaphylaxis. Bronchiolitis, these are younger patients, under 2 years of age. They'll usually have a fever. You may note it on chest x-ray. You'll have a perihilar distribution just because these are larger airways. Pneumonia, look for a fever and a white count and a consolidation on chest x-ray. It's not going to be diffuse wheezing. It'll be limited to one area. Upper respiratory tract infection, this is a different constellation of symptoms. They're not going to have wheezing. They'll have cough, rhinorrhea, congestion, but do remember that an upper respiratory tract infection can precede an asthma exacerbation. Cystic fibrosis, this is going to be a more long-term, usually diagnosed in infancy nowadays. Look for other cystic fibrosis symptoms, failure to thrive, malabsorption, diarrhea, recurrent pulmonary infections, and perhaps a family history. Remember, autosomal recessive, so the family history would be in siblings. It may coexist with asthma. So to recap, asthma is a reversible inflammatory disorder of the airways characterized by obstruction and hyperresponsiveness. Exacerbations, you should just confirm it with an albuterol nebulizer. It's harmless. If they improve, it's an asthma attack. The treatment is albuterol and corticosteroids, and remember to administer that supplemental oxygen. Patients should be discharged with a short-acting beta agonist like albuterol and to follow up with the PCP and also to continue steroids that were administered. 5 days. You don't need to taper. Long-term management is based on the frequency of the symptoms and how often the rescue inhaler needs to be used. That will be discerned at their follow-up appointment.